Hello, my friends. This is Dr. Abraham here. So today we shall have a quick look at seborrheic dermatitis, one of the common chronic recurring dermatitis that you will encounter in your practice. So you need to be well versed of how it comes about, the best way to manage it, and how to discuss with your patients. So as you can see in this picture, we start with a picture where we are showing you ear of an individual with a lot of scales and desquamation. You see this. You see also this black ground erythema because it's usually very itchy and irritating. Then this is a scalp of a child that also has these greasy scales on top, and this is all seborrheic dermatitis. So it is a common mild chronic eczema, typically affecting areas with high sebum production or large body folds, and the exact cause up to date is not fully understood, but closely it has been linked to this to one over or increased sebum production, which we call seborrhea, or presence of the commercial yeast, the Malassezia species, especially the Malassezia ovari or the Malassezia fafa. So when you look at seborrheic dermatitis, you usually have two forms. That's why I showed you two pictures. You have the adult form and then the infantile uh, type of seborrheic dermatitis. The common sites involved include the scalp, the ears, the face, the central chest, as well as the interverginous areas, where we call it the inverse type of seborrheic dermatitis. The exact cause is not yet known, and then you have the three things where we think that maybe someone has active sebaceous glands, then you're having abnormal sebum composition as well as infestation with the Malassezia species, currently also called the Pittosporum species. So it has also been associated as an early sign of HIV infestation. So if you have a patient who has this scales, especially in the seborrheic areas or in areas with a lot of sebum, you try to treat, there's no improvement. You may actually need to test them for HIV because it is one of the early signs of HIV infection. As you can see in this picture, if I magnify for you, so in this picture, we see this scaling around the eyebrows, with the erythema, also around the minor areas of the face, and all these areas have a lot of sebum, and this is where we usually see the seborrheic dermatitis. It's actually very common for you to see. So it was first described by Anna in the and in that time he called it. Who is the one who suspected that maybe it is due to the Malassezia fafa as a causative agent, but then this is still debatable because there's now a thinking it may be due to sebaceous gland dysfunction or even high amounts of Malassezia fafa. But then when later on we tried to examine and see if this is actually true, there was a realization that actually the amount or the quantity of Malassezia species on someone's face does not correlate with the severity of seborrheic dermatitis. So you may find that the quantity is actually the same in individuals with either seborrheic dermatitis or without seborrheic dermatitis. So later on in the 1984, with the discovery of this antifungal ketoconazole, and when they used it to try and treat seborrheic dermatitis, it was good improvement. That's why actually who was up to date may think it is the yeast that is causing the problem. So the current understanding is that you have multiple species of Malassezia, including Malassezia fafa, and may be directly involved in the development of seborrheic dermatitis. So depending on the type that you're looking at, if it is infantile, how common is infantile? Oftentimes, we usually see things self-limited, confined to the first 3 months of life, and I think by around 8 to 10 months, the child is clear. And then the adult type usually is a little bit more chronic, and it peaks around the 40 to 60 years, but you can also see it as early as 30 years, as early as 20, and depending. So prevalence is about 5%, and this is usually higher as if you assess the increasing age. So if you are to do a prevalence study for those aged 50 and above, you may find the prevalence being a little bit higher, even up to 20%. Then more commonly seen in men compared to women, and it has also been associated with HIV and other neurological and psychological disorders like Parkinson's disease as well as cardiovascular accidents like strokes and mood disorders like mania, depression, and anxiety. There's a thinking that there's genetic involvement, but up to date there's no confirmation. So currently we say there's no genetic predisposition or even any horizontal transmission from maybe parents to their children. So in the overview, if you look at Malassezia, it is a lipophilic yeast, and it is actually part of the normal flora. And oftentimes there's a thinking that it is normal flora, but can become pathogenic for unknown reasons. So we have it being a little bit now called the opportunistic pathogen because it is thought now to be driving the process of developing this type of eruption on the face. So it has different varieties. We have the Malassezia species causing different skin conditions, and that's why it is also thought to be the one causing the seborrheic dermatitis because we have it causing folliculitis, the Pittosporum folliculitis. We have it causing the pityrosis vascular. We have it causing the cup that is confluent and reticulated papillomatosis, and possibly it has also been linked even in atopy. And because we know that we have the atopy, the eczema of head and neck that is linked to Malassezia colonization, and all this usually gives conflicting. You have conflicting studies whether Malassezia is also the one underlying seborrheic dermatitis. But maybe later on we shall have a conclusion on that matter. Then, because of these studies, we find that the isolated Malassezia from the lesions is actually like you is what you see even in normal individuals. So there's no relationship between either the number of the yeast someone has with the severity of the disease, and you find that you find even those that are living with HIV, their load, yeast load, is actually similar to those that are not infected or who are not having seborrheic dermatitis. So you may find that even the Malassezia maybe plays part of the role, but not actually being the actual cause of the seborrheic dermatitis. So predominantly, we've said that it is located in areas that have active sebaceous glands. This include the scalp, the face, in the venous areas, and also the chest and the back. You can also have them there. Then there's a thinking of over sebum production being a little bit beyond above the normal, and this is a facilitated growth of Malassezia because they said it is a lipophilic yeast, and but this does not directly determine the disease severity. That is has to be noted. So when you look at the adult versus the infant forms, in infantile seborrheic dermatitis, sebum production usually peaks slightly after birth, and this is usually due to influence of the maternal hormones, the androgens. But later on, after around 6 months, the androgens go down, and then usually seborrheic dermatitis also clears. But when it comes to adult, there's also a relation to androgen-induced sebaceous gland production that is usually activated after puberty, and because of this, then you get adult onset. So if you look at the lipid composition, patients with seborrheic dermatitis usually show elevated triglyceride and cholesterol, but they have reduced free they usually have reduced free cholesterol, and in this case it is so that because of this we know that even the lipids, they usually have antimicrobial properties. So if they have them reduced, this particular one, triglyceride is the one the fungus feeds on. But if you have reduced free cholesterol, the low HDL, and then that's low density lipoprotein, which you have an microbial effect. That means that this favors the growth of this bacteria. And then we have also reduced P. acnes bacteria in cases of seborrheic dermatitis, and this usually suggests an imbalance in the skin flora. Because when we have what we call normal flora, these are the bacteria or microorganisms that reside naturally on our skin. So P. acnes is one of them, and we see that in patients who have seborrheic dermatitis, P. acnes numbers are usually low, so meaning that in those patients, the microenvironment favors more of the fungal proliferation against the bacterial proliferation. So when you look at the immune response to Malassezia, there's a thinking that there's immune involvement, especially in people living with HIV, but there is no conclusive proof. And the inflammation that usually is in seborrheic dermatitis may be due to the irritation caused by either the toxic metabolite of the bacteria, the lipases, or even the reactive oxygen species derived from these fungi or from disease that reside on the skin. So in the appearance, we see the sharply demarcated patches with a thin plaque, which can have either pink or yellowish color, depending on the skin type of the patient. And they will have these characteristic brand-like or flaky greasy scales. And in some areas, you can get crusting, and usually this is due to irritation because it's a little bit itchy, so someone end up scratching, so they can have erosions, as you can see in the picture on the side here. You see there's some erosion here, erosion there, with these scaly plaques, thin plaques with hypopigmentation. So common signs we've already mentioned: the scalp, the face, the ears, and occasionally the intertriginous areas. So we know that generally it is usually mild, but in some cases can be severe, especially in people living with HIV or any immune suppressive state. And if it is mild, sometimes there's just a slight discomfort, but moderate symptoms can occur as the severity increases. And usually it is localized, though sometimes can be generalized, and a few cases where seborrheic dermatitis has been actually reported to be erythrodermic have also been seen. So this is one of the conditions that can give you erythroderma. So when you go to the infantile type, the onset commonly seen around the first week after birth. This can persist for several months, and this, as you've seen earlier, it is due to the maternal androgens that usually stimulate production of sebum, especially on the scalp, giving rise to the typical presentation where we see a scaly crust mass covering the scalp. This one we usually call it the cradle cap, as you can see in this picture. Then additionally, you can have inflammation and then oozing, especially in the affected areas. So additional areas that can be affected include the axilla, the inguinal areas, the neck fold, the retroauricular areas, and this oftentimes they can have inflammation, they can have oozing, but they will have sharply demarcated plaques with some lesions which can show septolytosis. So complication, you can have candida or even bacterial infections complicating the entire area. And in some cases, you can have it giving you a psoriasiform picture or appearance, especially on the trunk. And then you can also end up with hyperpigmentation, which can occur in other areas of the body. So when you go to the adult type of seborrheic dermatitis, commonly seen on the scalp, on the face, and then also on the trunk. And these are the areas that have a lot of sebum production. So if it is the scalp, sometimes patients can have pruritus and inflammation. Oftentimes it is worse in males, and it can also present with alopecia. And also the skin can also be a little bit more sensitive, especially it can occur when there's sun exposure or even heat, if they get febrile illness or any harsh treatment that can trigger a flare. And then still the complication, you can have things like pruritus, you can get pitosporum folliculitis, you can get other things like HIV has been associated with severe forms. So if they are coexisting together, you can actually end up with the erythrodermic type of seborrheic dermatitis. And then the cause is usually chronic and relapsing with systemic symptoms rarely reported. But you can get even flares which can occur after withdrawal or reducing the dose of corticosteroids that you're giving. So this is how it will look like. We've already talked about this scaling with erythema, and then these thin patches which have a very fine brand-like scales. So if you take off a biopsy, this is what we usually see. You see a spongiotic type of picture, similar to what we see in other eczemas. That is why it is also thought to be an eczema. We see a spongiosis with lymphocytic infiltrate, which can go as high as the epidermis, as you can see there. As you can see there, those are lymphocytes. And then you have this spongiosis within the epidermis. So in chronic cases, you can have things like acanthosis that we usually see, also focal parakeratosis, as you can see here. This is parakeratosis, retained nuclei in the stratum corneum. But in this case, you'll have no neutrophil, you'll have no abscesses, as you see in psoriasis, and then you have the confluent parakeratotic layers. So that is how seborrheic dermatitis will appear on a slide. So if you look at differential, if it is infantile, you can think about things like atopic dermatitis, lichen dermatitis, candidiasis, streptococcal intertrigo, infantile psoriasis, and other rare conditions like Langhans cell histiocytosis, and then also nutritional dermatoses like acrodermatitis enteropathica, the one you see in zinc deficiency. And then also Linnaeus disease, which is also called eczema in immune suppression. And in this case, usually this patient have a generalized orthodynamic picture of scaling and erythema. That is in infantile. So if it occurs in the prepubertal children, you can think about things like tinea corporis, ptosis, and anaesthesia, especially if you have an adherent scale following the hair follicles, that is your ptosis and anaesthesia, and it can either be due to seborrheic dermatitis or even psoriasis. If it is the scalp, you can think about psoriasis, that is an adult, xerotic skin, that's atopic dermatitis, dermatomyositis. You can think about rosacea, SLE, if it is on the trunk, pityriasis rosea, and the rest. So these all are differentials to think about if you have a patient with seborrheic dermatitis. So in terms of treatment, if it is infantile subderm or seborrheic dermatitis, we can use things like emollients, especially when the child is bathing. And in this case, this can work for this is like the primary approach. You use things like olive oil that tries to remove the excess scale and then tries to moisturize the skin and minimize irritation. Then you can think about ketoconazole cream in case if it is persistent. And then you can also do low potency corticosteroids, especially if there's rudiments and pruritus, and this is only done for a short period of time. So you can give a drug that has both corticosteroid and an antifungal, like hydrocortisone together with either conazole or ketoconazole, and this can be given for just a short period of time. Then you can also use mild shampoos. For the shampoos, you have to be a little bit very careful because some of them can be a little bit irritating, especially for the infantile skin. If it is adult, we usually use still topical azoles. You can also use shampoos like Keto Plus shampoo, which has ketoconazole and zinc pyrimethione. Then you can also use cyclopyrox oramine, which also has both antifungal and anti-inflammatory properties. You can also maintain afterwards because this is a treatment that we usually give for acute treatment. Then after that, you can now put the patient on routine or what we call high maintenance. So in this case, if they're using maybe a medicated shampoo 3 times in a week, then they can use to 2 times in a week or even once in a week. But in cases where it is very resistant, you can use low potent corticosteroids to try and calm down the inflammation. So in the second line, you have the pyrimethione, you have selenium sulfide, you can have potash shampoo as well as the topical calcineurin inhibitors like tacrolimus and imecrolimus. So that's the management approach in seborrheic dermatitis. So you have now first categorize, is it infant or is it adult seborrheic dermatitis. Now, if it is the first time, you want to go slow, you want to use an azole like ketoconazole applied maybe twice a day for a month together with maybe a medicated shampoo, which can have either ketoconazole or which can have other things like zinc pyrimethione together in that shampoo. So use that for a couple of months, and then if there's good control, then you can now taper that down, and then the shampoo can be used either once or even twice a week. And then keep monitoring the patient. If there's no improvement, you have to check for HIV as well. Thank you for listening. See you in the next video. God bless you.